100. So what is normal heart rate? 60 to 100. And what is tachycardia? So anything greater than 100 is tachycardia. So let's clarify some confusing conditions. So this whole today's thing is focused on confusing points. Is it A or B? Okay. So sinus tachycardia, inappropriate sinus tachycardia, sinoatrial reentry tachycardia. How do you differentiate these three things? And they look the same. So if the rate is greater than 100, it could be any one of these three things. So all three of these conditions, sinus tachycardia, inappropriate sinus tachycardia, and sinoatrial reentry tachycardia, all of them, rate is greater than 100. There's a P wave in front of every QRS complex, and the QRS complexes are all narrow. Okay? But how are they different? So the patient is at rest, and you are checking the EKG or you're checking the heart rate. If there's a reason for the rapid heart rate at rest, let's say a patient just had coffee or he's just stressed from being in the hospital, that is sinus tachycardia. So let's say there's no reason for the patient to have a high heart rate. The patient is relaxed and happy and laughing and not stressed at all. And there's no insight into why he's in the hospital. Okay. And he still has tachycardia. That would be inappropriate sinus tachycardia. Now, how about the third one? Sinoatrial reentry tachycardia. So in this condition, and all three of them look exactly the same, there is no way to tell from the EKG alone. The way you can tell is if you do a carotid sinus massage with a sinoatrial reentry tachycardia, it will not slow down. That's the only way you can tell if it is sinoatrial reentry tachycardia. Looking at the EKG alone or the rate alone, there's no way to tell. Okay, so those are the three you need to remember. Okay, then coming to atrial tachycardia. The main thing about atrial tachycardia is the P waves look unusual. What if we change this? Let's see, 1 second. Yeah, here it is. Downloaded some pictures here. It may be just it's easier to bring it up on Google as an example. Just to show you a quick example of so multifocal atrial tachycardia images. See, here's a good picture, multifocal atrial tachycardia. So what you see is the P waves look odd. How is this different from atrial fibrillation? Atrial fibrillation, you cannot make out any P waves at all. Whereas in atrial tachycardia, you can make out the P waves. So the differentiating point between atrial fibrillation and multifocal atrial tachycardia, and this is a point often the emergency room doctor and the cardiologist dispute over. The emergency room doctor almost always reads this as atrial fibrillation. In reality, this is not atrial fibrillation, well, because the label says so, but there is strange looking P waves, and in order to call it multifocal atrial tachycardia, you have to see at least 3 different types of P waves. There'll be at least 3 different types of P waves, and the overall, these are the QRS complex. You can see that the RR intervals are continuously changing. So it's an irregular rhythm, and there's multiple types of P waves. That's how we can tell it is um, multifocal atrial tachycardia. Whereas if it is atrial fibrillation, you simply cannot make out any P waves at all. No matter how you look at it up and down, there is no identifiable P waves, one. And two, the RR interval is constantly changing, so it is irregular. Okay? So the irregularity plus absence of P waves is atrial fibrillation. Whereas multifocal atrial tachycardia, there are P waves present, but they all look different. If it is just focal atrial tachycardia, let's say. Okay. If it is focal atrial tachycardia, the P waves look strange, but it's the same P wave throughout. So the appearance of the P wave does not change. It's just that it does not look like a normal P wave. That's how we can tell it is atrial tachycardia. Of course, it has to. Of course, the rhythm has to meet criteria for tachycardia, which is more than 100. P waves look odd, but it's the same P wave that is repeated all through the tracing. Okay, so that's how we can tell it's focal atrial tachycardia. Okay.
I have a question about the flutter waves because multifocal, I feel like it looks similar to atrial flutter.
Yeah, we'll come to that soon. So flutter looks completely different. So flutter, we'll come to that. Okay, so unifocal atrial tachycardia, RR interval stays the same because all the complexes are from the same origin. Multifocal atrial tachycardia, irregular, chaotic, looks like atrial fibrillation, but you can clearly see P waves. There'll be at least three types of P waves. So atrial flutter. Let's see. This is a classical appearance of atrial flutter. This kind of sawtooth appearance. That's very classic for atrial flutter. But like I said before, if the ventricular rate you're seeing is around 300, and it could easily be atrial flutter that looks like a supraventricular tachycardia. So that's something. In that situation, what you would see is if you count just the R waves alone, the rate would be around 150. Okay, so what is happening is um, some of the flutter waves are hidden behind the QRS complex. So the QRS complex rate would be 150. So the real rate that's not obvious is actually around 300. So it's a flutter rate. So flutter, um, if you see supraventricular tachycardia and the rate is around 150, it is suspicious. It may be atrial flutter with 2:1 block. So you're seeing only um, one of the, for every two P waves, one may not be visible because it is hidden behind the QRS complex. Okay, anyway, this is the flutter characteristic appearance. Look at that. So it has that sawtooth appearance, and this is what, one, two, three. So there's a 3:1 block, right? And the type of tachycardia is junctional tachycardia. So the concept to understand here is in junctional tachycardia, the AV node itself is functioning as a pacemaker. So this is different from AV NRT because in AV NRT, AV nodal reentry tachycardia. The impulse is still originating in the sinus node. It's just that once it reaches the AV node, it's running in circles. Okay? Now, junctional tachycardia is a very characteristic look. So a lot of these rhythms, the best way to identify that is, uh, simply recognizing the pattern. If you've seen enough of those, then you'll automatically spot it. So junctional tachycardia, first of all, the QRS complex is extremely sharp looking. See, they're very, very sharp looking. And the second point is um, the the junctional tachycardia has a gradual onset and offset. So it comes on very gradually, goes up very gradually. It's not abrupt. That is one important point. Whereas AVNRT, it'll be abrupt onset, abrupt offset. Okay, that's one of the ways you can tell. Now the P waves, if they are inverted in 2, 3, and AVF, that should be a clue that the atrial depolarization is coming from an unusual direction. Okay? But the main thing to remember is the QRS is extremely sharp looking, and the P waves, actually, you may or may not see a P wave. Okay, you may see a P wave right before the QRS complex. You may not see a P wave at all because it may be hidden by the QRS complex, or you may see one right after the QRS complex. Um, so uh, that kind of combination of extremely thin-looking QRS complexes with a P wave in odd locations. Okay? Um, And then the other point to remember is junctional tachycardia has gradual onset and offset. So this is junctional tachycardia. There is 3 EKGs. So here you can see the P wave is right before the QRS complex. Okay? It's a tiny, tiny little um, P wave that's right before it's inverted, it's upside down, and it's right before the QRS complex. Okay? And here, this is another junctional tachycardia. You cannot even see the P wave at all because the P wave is hidden by the QRS complex. So again, you are seeing, first of all, make sure this tachycardia is more than 100. Second, um, are there any P waves at all? The P wave is completely missing, and these QRS complex are extremely thin looking. So, that's what junctional tachycardia looks like. And here is another example. Again, this is a junctional tachycardia. The P wave is actually appearing after the QRS complex. It's kind of hard to see, but it's there. It's a little tiny notch there. Okay, and then AVNRT. So the main thing to remember about AVNRT is abrupt onset um, and offset. Okay, so it comes on abruptly and then it goes away. So there is the slow fast type, which is usually the only one you'll ever see, and then the fast slow type. So here we're only going to look at the slow fast types because if we throw in too many things, we'll just end up being confused and won't accomplish anything. So let's focus on what is common. Okay, so AVNRT slow fast type. There is 2 things you look for. Okay. Um, and see, this is how it works. So the initial wave is going down so we are looking at the slow fast type. So the initial wave is coming through the slow pathway and um, and the second part is what is causing the retrograde wave, the wave that is going in the opposite direction. So the antigrade one is creating the QRS complex, and the retrograde one is creating the P wave. Okay, so what we are seeing as a characteristic look is there is a pseudo P wave. Well, it's a P wave, but it's called a pseudo S wave because it looks like S, right? Um, so it's actually a P wave that's appearing right after the QRS complex. In which leads 2, 3, and AVF. So in 2, 3, and AVF, you see this funny looking S wave or a pseudo S wave, which is in reality a P wave. Yeah? And the other finding you get is in lead one, and lead one is basically simply a mirror image of what happened in the inferior leads. So in lead one, you're seeing a pseudo R wave. So there's a extra R wave right after the R wave. Okay? So that's a combination to remember in AV and RT. Okay? There is a um, little tiny pseudo S wave in inferior leads and pseudo R wave in V1. So that combination. Okay. So now coming to AVRT. So AVRT is more problematic. Okay. Um, so say, so how do we differentiate AV? Is it AVRT or AVNRT? Okay. Now here you saw there is a P wave, which is not called a P wave, it's called a pseudo S wave. It's appearing right after the QRS complex. Okay, that's what is happening in AV-NRT. This fake P wave appears right after the QRS complex. That's the main thing to remember. Okay, but if it is AV-RT, that fake P wave or the retrograde P wave occurs much later. Okay, so it does not appear right after a QRS. It will appear sometime during the T wave. So here it says R P interval greater than 70 milliseconds. But the practical way to remember is this retrograde P wave in AVRT appears much later, appears sometime during the T wave. And that's how we can tell. So and the best way to check that is V1. Okay, so P wave is seen as a small notch beginning of T wave, indicating that it's likely to be orthodromic AVRT. So AVRT, AVNRT can look alike, but you have to remember the mechanism is completely different. So AVRT, what is happening is there's an accessory pathway. Usually there's that Wolff-Parkinson-White pathway, or it could be another. There's three different pathways. So if any one of those pathways is present, and remember, what does ortho mean? Ortho means the correct way. Ortho means the impulse that travels from the atria to the ventricle travels along the correct route, which is through the AV node. Yeah, so it travels through the AV node. That's why it's called orthodromic. So in AVRT, the initial impulse, which travels from the atria to the ventricle, travels through the AV node. But the return trip is through the accessory pathway. That is orthodromic. And that is the common thing you see. Yeah? Whereas in AV-NRT, there is no accessory pathway. That's the main thing to remember. In AV-NRT, there's absolutely no accessory pathway. In AV-NRT, everything is happening right inside the AV node itself. Okay, and now of the two types of AVRT, there is orthodromic type, antidromic type. The main difference between these two is orthodromic type has a narrow QRS complex. Okay? Antidromic AVRT is what closely resembles ventricular fibrillation. Sometimes you simply cannot tell if it is not ventricular fibrillation, ventricular tachycardia. So you cannot tell if it is antidromic AVRT or ventricular tachycardia. We'll come to that in a minute. So this is a couple of different examples of orthodromic AVRT, where the retrograde P wave occurs much later. Sometimes it can be hard to tell, but if you look closely at especially the V1 lead, you can see there's a little notch in the T waves. You may not see it in all the T waves, but there'll be notch. What that means is that retrograde P wave is landing on the T wave at some point, so much delayed after the QRS complex. Okay.
Yeah, I think I could see the notch, but like if you zoom into that picture, it's much clearer in V1.
Yeah, it's hard. How do we zoom on this? Let's see.
Actually, could you maybe upload this document to the chat?
Yeah.
Thank you.
Yeah, there wasn't enough time to get examples of each, but the main thing to remember about AVRT is so if you look online at many of these examples, they will start by saying, oh, this could be AVNRT, it could be AVRT. The way you differentiate AVNRT versus AVRT is AVRT that P wave lands much delayed after the QRS complex. Whereas with the AVNRT, it will be somewhere in the same vicinity. It will be right after something. So the delay is what tells you. And other important point to remember is the difference between orthodromic AVRT and antidromic AVRT. So antidromic AVRT is wide complex. Okay, and okay, so antidromic AVRT versus ventricular tachycardia. It's hard to tell, but and when in doubt, what do? You manage it as ventricular tachycardia because it's way more dangerous. But you can actually see in antidromic AVRT, there'll be a little notch in the QRS. So let's see. Okay, see, this is orthodromic, narrow complex, okay? So that you won't mistake for ventricular tachycardia. When you come to antidromic is what the problem is. Let's see, antidromic. See, antidromic looks exactly like a ventricular tachycardia. But let's see, you can see there's a little notch. See, you can see that notch. Let's zoom in. Let's see if it can make it bigger. Oh, something else. Okay, here it is, zoom button. So see, in that down slope, you can see that little notch. Can you see that? Little notch here. So that notch you won't see in ventricular tachycardia. So let's see a ventricular tachycardia. Well, this one has a notch, but okay, that looks like a good picture. Hard to tell if that's a notch or not. But anyway, uh, the, but there's no notch on the downslope anyway. And oftentimes, remember, some of these tracings uploaded on the internet, they may not be sure what exactly it is. So here's a ventricular tachycardia. See, it's really, really hard to tell. But but this one is kind of blatantly ventricular tachycardia because it's such wide complex, huge, huge wide complex, plus everything is exactly same height, right? So that's the other point to differentiate monomorphic versus polymorphic ventricular tachycardia. Uh, uh, Polymorphic, the amplitude keeps changing. Monomorphic, the amplitude is the same. See, this is another case of ventricular tachycardia. See, it's really hard to tell.
But you can't say this is like ventricular flutter, right?
A flutter is different. Flutter, we're coming to flutter in a second. Flutter is a completely different thing. Let's see, oh, we zoomed out again. Okay. All right.
So the
So,
main way
so
to
the
identify antidromic AVNRT was with the notches?
with a notch, but again, you can oftentimes you simply cannot tell at all. So that's why the idea is if you're in doubt, simply manage it as ventricular tachycardia, because of the two, ventricular tachycardia is far more dangerous, and most of those patients will be unstable, and unstable means you cardiovert. Okay, so here's the section. So ventricular tachycardia versus ventricular flutter versus ventricular fibrillation. Okay, ventricular tachycardia means it's a wide, complex, regular tachycardia up to 250 per minute. Okay, so in a 10-second standard EKG, you will see 42 beats, so 42 times 6, so that'll be around 250. Okay, and this 250 is the number to remember. Okay, once it exceeds 250, you don't call it ventricular tachycardia anymore. Then it's ventricular flutter. So the only difference between ventricular tachycardia and ventricular flutter is the number, is the rate. Okay, so both are wide complex, regular tachycardia, and they look this kind of huge, huge waves which are unmistakable. Okay, and if you see something like that, it's ventricular tachycardia until proven otherwise. Okay, don't worry too much about AVNRT. First of all, AVNRT orthodromic is rare. Okay, ventricular tachycardia is common. So always assume it's ventricular tachycardia. Of course, you can. This is more of an academic debate. Which one is it? Okay, in reality, all these things are ventricular tachycardia. Okay? But the ventricular tachycardia versus flutter, the only difference is the rate itself. You call it ventricular tachycardia up to 250. Once it exceeds 250, that's when you call it ventricular flutter. Okay? That's the only difference between the two. And in reality, you will never ever see ventricular flutter because by then the patient is so unstable, they are only seconds away from ventricular fibrillation. Okay, so usually, if you are seeing the patient in ventricular tachycardia and you're starting to treat, you're cardioverting, or whatever, um, at any moment they will go into ventricular fibrillation. Okay, so that brief transitional time, few seconds that you may actually see flutter, is more of an academic thing. You will never actually see it. But for academic purpose, you have to remember ventricular tachycardia rate exceeding 250 is flutter. Yeah. Now, fibrillation. So this is flutter. Fibrillation, the main thing to remember is you cannot identify any waveforms there. You cannot identify um, atrial waves. You cannot identify ventricular waves. Absolutely nothing is identifiable. then that's ventricular fibrillation. Okay, so those are the main points. So what else are confusing points?
Also, regarding the ventricular tachycardia, there was a lot of criteria that they listed. Do we have to go through
Criteria?
that one?
Let's see. So it is when it's regular, okay? It's wide complex, and the rate is rate is greater than 100 and up to 250. So other criteria, let's see.
Also, if there's any questions from the participants, just let us know.
Okay, so other than that, so the purpose of this one was simply to clarify these different difficult points. But let's see, criteria of ventricular tachycardia. Okay, let's see. Do you have that criteria handy?
Let me check 1 second.
Okay, here is some criteria from Google. Rate exceeding 100, which is tachycardia. 3 or more consecutive beats, and it's regular.
So I sent you this video that was about VT versus SVT with aberrancy. It's just like a minute, but if you just open that
Okay,
one, it would show you like a list of criteria. And it doesn't
okay,
go
let's see.
through like what is SVT, but
This one,
yeah.
okay, let's see. Loading. Maybe YouTube doesn't want to be inside Zoom.
But you can skip to the middle of the video because then it shows the list of criteria.
Yeah, ventricular tachycardia, you cannot find the axis. It's not possible to find axis. See, how do you find axis with that? That's just a nonsensical thing.
Yeah, but it depends on if it's like negative deviation or positive.
Yeah, but if there's VT, you really cannot tell much from the because VT is so obvious. VT is so obvious on a thing. Okay, so there's the criteria they're saying. Very wide QRS complex. Yeah, it has a very unmistakable look. This kind of huge mountains.
Yeah, but there's also
Uh,
more criteria if you could just skip to the rest of the video. Just go to
okay,
the
let's see.
like last part. Just skip all the way to like the end that shows like
And these things,
Mm-hmm. Yep.
yeah, yeah, yeah. These are academic things. So yeah, why not? We can write those things in the exam. But yeah, but on a practical level, the way ventricular tachycardia is diagnosed is simply from appearance. Nothing else looks like it.
Okay, but like what do they
Yeah,
mean with SVT with aberrancy? Does that just mean the all the other types of diagnosis basically or
yeah. SPT with aberrancy, that looks different. It doesn't look like this. Let me
so it
see.
basically means like RBB or LBB?
SVT. Any kind of tachycardia. Let's bring up an example here. See, that's only the. It's not. See how different this looks from the ventricular tachycardia. So it's not possible to mistake those two. The reason the SVT with aberrancy is important is when you when you think about wide complex tachycardia. So wide complex can be because of ventricular tachycardia itself. It can be torsatus, or it can be any kind of supraventricular tachycardia uh, that has AV block of some kind. Okay, and you know any of these blocks because that simply prolongs the QRS complexes. But it never looks like ventricular tachycardia.
So what's the
But
criteria for SVT? Is it just like wide complexes or
well, if it is a supraventricular tachycardia, there will be a P wave will be identifiable first of all.
also we got a question about can you explain about atrial fibrillation with LBBB that it looks like ventricular tachycardia sometimes. So basically AFib with LBB.
Yeah, yeah. You can see first of all the RR interval keeps on changing. RR interval keeps on changing, and there is no P waves at all. So that tells you it's atrial fibrillation. But where it gets confusing is because the complexes are wide. Because if it is ventricular tachycardia, the whole thing will be regular. That irregularity will not be present. So once you see that the RR interval is constantly changing, uh, meaning uh, it's irregularly irregular. Plus, there is no identifiable P waves. The combination of those two things should tell you it's atrial fibrillation. The other thing that can trip you up is, okay, it looks extremely irregular. RR intervals are constantly changing, and there's P waves. Then what is that? That is multifocal atrial tachycardia.
So here we don't really see P waves.
Where there's no P waves at all. See, there's nothing. Yeah, it's the that is
And this
the
isn't
main.
atrial flutter because
It's not flutter because flutter is regular. Yeah, flutter there is no flutter is always regular. It has this nice looking sawtooth pattern. And if there's aberrant conduction, it will be flutter with the 2-to-1 block or 3-to-1 block or 4-to-1 block, whatever. A 2-to-1 block is very common.
so what should we look
So
out for that we could confuse this one with? It could be confused with ventricular tachycardia.
no, because ventricular tachycardia is always regular. See, if you open another tab. Okay, let's see. See, ventricular tachycardia is always regular. See how nice and regular it is. Whereas atrial fibrillation with actually what you see in reality is atrial fibrillation with Wolff Parkinson White. So that's a
Yeah,
very
actually, we have a
common.
question about that. Someone wants to see, like, explain how atrial fibrillation looks with WPW. But can you say,
That
like,
that is,
would this be the same as SVT with aberrancy or not really? It's
it's
or
one of
those are
them. Yeah,
okay.
it's one of them. Yeah. I don't know why Google is so slow. I guess there's too many windows open or something. Yeah, the computer has been trying to do an update for the last couple of days. It wants to open only one window at a time. Okay, so a fib with Wolfram's in white. Okay, there it is. Okay. Okay.
I think you have too many tabs open. And also that
Yeah,
YouTube video is on the side, so
yeah, there's thousands of things open here actually. Yeah, a computer has been asking for a upgrade, not upgrade, but update. Okay, there's you can see see that it's not getting any bigger, but you can see the picture, right? So what you see here is extremely irregular. Okay, extremely irregular. Um, and
but this one has delta waves, I think, because
yeah,
that's what
those are
makes it
probably the yeah. It's that
WPW.
yeah. It has that little triangular thing there.
Ja, där Viktor. Men jättesöt. Gud så underbart. Även om det inte bara är utsidan.
Yeah.
Såklart. Du vet va? Eller Fredrik? Va? Nej, låt inte gå ut över.
So this one is atrial fibrillation because it's so jagged looking.
So, well, the RR interval is constantly changing, not because of jag looking. So the RR interval See, now it's changing throughout. So there's only a couple of instances where you will see the RR interval changing all the time. One is in atrial fibrillation, other one is multifocal atrial tachycardia. So multifocal, and the difference between these two is multifocal atrial tachycardia, you will actually see P waves. It's just that there'll be several types of P waves. Whereas atrial fibrillation, there is no P waves. Otherwise, they look the same. So that's why there's very often the emergency room and the cardiologists are arguing over which one is it. And
And we have one more question about how to differentiate between ventricle and atrial arrhythmia. So AFib versus VFib.
if it, that's very easy. So this is AFib, okay? This is AFib where you can in AFib you can see QRS complexes. In atrial fibrillation, what you don't see is atrial activity. In atrial fibrillation, there's no atrial activity, whereas in ventricular fibrillation, there's no activity of any kind. See, this is atrial fibrillation. You cannot identify any activity. You cannot identify any ventricle. Can you see any P waves? No. Can you see any QRS complexes? No. Whereas with the atrial fibrillation, you can see the QRS complexes clearly. Only the atrial activity is missing.
Okay, we have another question, how to count QRS complex length in ventricular tachycardia?
You mean
So maybe how to
duration?
tell, is it like wide or something? But usually they don't ask like the exact measurement, but they just want to know, is it narrow or wide?
Wide, anything greater than 3 small squares for EKG purposes. Wide complex QRS means anything that is at least 3 small squares, which is 0.12 second.
So like ventricular tachycardia is always wide, right? It's not narrow.
Ventricular tachycardia is much wider than that. Ventricular tachycardia has this huge, massive appearance, but regular.
Yeah.
See, this is ventricular fibrillation because there's big waves, but there's no uniformity. Ventricular tachycardia is very nice and uniform. Fibrillation is, there's nothing there. You cannot identify anything. It could be just a kid drawing a line there. There's absolutely nothing there. See, this is ventricular fibrillation. This is ventricular tachycardia. Even though both are dangerous, with ventricular tachycardia, it's nice and regular.
Okay, since we're kind of running out of time, are we gonna go through some of the ECGs or?
ECGs, there's a lot of them. So best thing to do is I'll go through them and mark each one and make it into a bunch of screenshots. Okay, make it into a bunch of screenshot and write comments on top of each tracing you send, and
Mhm.
send it as a bunch of
Yeah, that
screenshots
sounds
as a zip
good.
file. Yeah,
Can you
so that way
actually,
it'll be
before people leave, could you put that Word file in this chat so
yeah,
people
yeah,
can download it
yeah.
now?
How do we do that?
So you just download the file. You could send it to my WhatsApp and I can just put it.
Okay, we'll send it to WhatsApp. Okay.
So the ECGs, I can send that probably to the joint group of FAMSA, like the WhatsApp. If you guys are in that,
Yeah,
then
yeah,
you'll get the ECG collection. Otherwise, I'm not
yeah.
sure how to
So
send that one later.
okay, let's see this one. What's it? Explanations. Okay, let's see. 1 second. Okay, here it is, and we'll send it on WhatsApp. Yeah, it's really hard to find these things. Okay, here it is. Yeah, the computer is unhappy at the moment. Okay, anyway, we'll send it in a couple of moments. Oh, here it is. Yeah, we'll do a restart and then Windows upgrade and send this. Can you still hear?
Can you just click the plus button? Maybe then it'll get sent.
No, there's too many things open here. That's the problem. Thousands of tabs open, and it's been asking for a Windows update for the last few days.
So the annotated ECGs, you're gonna send it to the FAMSA group. So those you guys will get if you're in the FAMSA group on WhatsApp. So I send the WhatsApp link in the chat. You guys can join there. And then this Word document, I hope we get it in this year.
Yeah, we'll send it in a minute. Okay, so I think we have to hang up now and then.
Okay, then I'll send it
restart
to us.
Okay, then we'll send it
I'll
to you
send
as
that
well.
also to the FAMSA group, all right? So guys, join the FAMSA group. It's in the chat. If you have any other questions left, let us know. Otherwise, have a great weekend and good luck for cardiology. Thank you for attending.
Fine. Okay, all right. Okay,
Thank you, guys. Goodbye.
Let's see.
Okay, I'll end the recording now.
Okay.
Do I pause that?